I'm live tonight. I'm going to be talking about endometriosis and hormones. Now, I'm not a gynecologist, I'm not a womb expert, but I am a general physician who specialises in hormones. So firstly, what is endometriosis? It's something that's talked about a lot. So I'm just going to give you a basic definition first. So in endometriosis, we have tissue that is like the lining of the womb tissue, which is called the endometrium, but it's elsewhere in the body. So sometimes it can be just in the pelvis, just outside the womb. Sometimes it can be on the fallopian tubes, on the ovaries, but it can also get elsewhere. So it can be on the bowel, it can be on the bladder, can even go up to the lungs. It can be anywhere in the body. When it becomes within the lining of the womb, so actually in the muscle part of the womb as opposed to on the lining, then it's called adenomyosis. So endometriosis and adenomyosis are actually very similar in that there's tissue like the lining of the womb in a place that shouldn't be there. So it's not the actual lining of the womb that's moved, it's just these tissue deposits, if you like, that occur. Now, for many reasons, people don't know why it happens. When I was at medical school many years ago, I was taught it was due to retrograde menstruation. So like the lining of the womb that's shred when we have periods, like goes the wrong way and then goes up around the body. But we know, like, how does that work if it's going to the lungs? It doesn't make sense. So lots of people don't know why it happens. You've got inflammatory cells there, if you like. And what happens if you think how the lining of the womb responds to hormones? So normally the lining of the womb will change according to where you are in your menstrual cycle. So at the first half of the cycle, there's or in the middle of the cycle, you ovulate, produce an egg, and you get a peak of estradiol, progesterone and testosterone, and the egg is released. The second half of the cycle, there's more estrogen and progesterone actually, and the lining of the womb thickens, and then it shreds because there's a big drop of those hormones. So we know that the lining of the womb is responsive if there's estrogen. Estradiol is like natural form of estrogen. That if there's too much estradiol relative to the progesterone, you can get thickening of the womb, which then shreds. So we know that endometriosis tissue can be responsive to estrogen. Now, there's so little that's known about it. It can be really confusing, and then treatments can be confusing. How to make the diagnosis is confusing. And actually, when I speak to different gynecologists, they all tell me different things. So in medicine and in life, when people tell you different things, it's often because we don't know the answer. And also, everyone is different. We do know that endometriosis is very common, and it probably occurs in around 1 in 10, so 10% of women. But we also know it can take many, many years for the diagnosis to occur. And that's often because the symptoms really vary between women. A lot of women find that they get symptoms before their periods, when the lining of the womb, if you like, is the most, when there's more inflammation in the endometrial deposits, or endometriosis deposits rather. But what we don't know is whether more extensive endometriosis causes more symptoms, or why is it some people get more symptoms than others. Now, a lot of symptoms people get are pain and discomfort. Sometimes people can get abnormal bleeding. Obviously, if it's in the lungs or the diaphragm, then it can cause even bleeding problems and breathing problems, It really does vary depending on the location of the endometrial deposits. But often the big thing in a history is that the symptoms change throughout the monthly cycle. And that's where, and I've said it many times already, that women need to be listened to, and they need to be taken a really, really clear history. So this is all a general rule of thumb, but generally, if symptoms are changing and often worsen before the period starts, then it could be related to hormonal changes and endometriosis. Or if there's certain times of the month where things are worse, then we need to be thinking about endometriosis. Now, it's hard because a lot of people get pain when they have their periods, a lot of people have bloating, discomfort, and not everyone has endometriosis. The other thing is it's quite hard to make the diagnosis because there's no single test that will determine if someone's got endometriosis or not. Some of the ultrasound scans are really sensitive now, especially when they're done as a vaginal ultrasound. And some of the ultrasonographers and gynecologists that scan, especially the ones that are really experienced, can sometimes see endometriosis deposits, depending on their location, of course. Sometimes it can be other scans that can pick it up, but often people have what's called a laparoscopy, which is where it's like keyhole surgery, but they're not removing or doing any of surgery, they're just looking. So it's just using like a little camera to look inside the abdomen to see whether there's any endometriosis at all. But they don't always see it, and when people have endometriosis, the amount they see is not always proportional to the pain. And so sometimes people might look like they've got quite mild endometriosis when they're looking through a laparoscope, but actually the woman's saying they're really severe symptoms. And that's really difficult sometimes, because often women aren't believed or not listened to, because when they do a scan or when they have a look through the operation, they say, well, there's not much endometriosis there. But we don't know why some people have more severe symptoms than others, for example. Why people get endometriosis, again, we don't know. It's something that happens in women, and it's more common in women who are fertile. And it can be due to, obviously, triggered by changing hormone levels, especially when people have more chaotic hormones when they're adolescents. But anybody can get it at any age. Adenomyosis can often cause quite a lot of pain and discomfort and heavy bleeding. And so, again, it's something to think of. And increasingly, we see a lot of people who are perimenopausal who have adenomyosis. And we do a scan because they have bleeding on their HRT. And then the diagnosis of adenomyosis is made. And then often we find that they've had quite heavy periods for quite a long time, and also quite painful periods. So they've probably had adenomyosis for a long time. Now, there are different treatments, and really I wanted to spend tonight talking about what happens to endometriosis and adenomyosis in women when they're perimenopausal or menopausal. But just briefly, treatments really vary. Obviously, when there's pain control is very good, but no one wants to take painkillers in the long term unless they really need them. So it's looking about how to treat the underlying cause. Now, quite often people will give the contraceptive pill because it means that you've got a sort of the same level of hormones in the body throughout, to stop this sort of change in hormone levels, which can trigger endometriosis being worse. I feel a bit hesitant about this because many of you know contraceptive pills contain synthetic hormones, so they've been chemically altered. So we don't know whether they reduce inflammation the same way as natural hormones. And we don't know whether some contraception use is associated with a higher risk of endometriosis in the future. It's something that's never really been done, but it's certainly on the back of my mind, and I wonder more and more whether contraception is the best thing to offer people in first line when they've had a diagnosis of endometriosis, because the way that the synthetic hormones work is that they can sometimes actually increase inflammation or not suppress inflammation the same way that our natural hormones do. And this is me talking from knowing a lot about the pathophysiology and also clinical practice, not having read papers because I'm not aware there are good papers about this. Sometimes the gynecologists give something like Zoladex, which is an injection to block hormones, which you would think would help, and it might help some of the endometriosis symptoms. But then if you're blocking all the hormones, you're basically giving someone a menopause. And if they're young, you're switching off all their hormones. So you might be replacing one problem with another. If someone is given Zoladex, then it's really important to talk to somebody who understands giving hormones back as well, because you can still have hormones but give them at a constant level at the right dose, the right time for that individual, and that can actually improve the way endometriosis is for that person. Sometimes people have operations and have the endometriosis deposits removed, and I've certainly spoken to a lot of people over the last 30 years of being a doctor hearing by lots of women who have multiple operations. They have the endometriosis deposits removed, they think it's going to improve, and then they're still having symptoms, or they can get some adhesions or scarring where they've had the surgery, which then can mean that they have to have more surgery to have these adhesions removed. And you've got this constant cycle of people going in and out of having surgery. So if you are having surgery for your endometriosis, make sure it's someone that's really experienced and that they can really talk to you about the benefits and risks of surgery as well, and any long-term problems. If the endometriosis is quite well confined in a small area, then surgery is often easier to do. Obviously, if you've got deposits on the bowel or the bladder, sometimes the gynecologists ask bowel and bladder surgeons to come too, and the operations can be more extensive. But having it cut out doesn't always mean that the endometriosis has gone. Sometimes the consultants or the surgeons are very confident that all the endometriosis has been removed. So everyone is very, very different, but it's very important if you have surgery, then you speak to your surgeon and find out exactly what they did and whether they're confident the endometriosis has been removed or not. Some people have a hysterectomy, especially if they've got adenomyosis, or some people will just have the ovaries removed, or they'll have the endometriosis deposits removed and still keep their womb and their ovaries. It really, really varies. Even after surgery, sometimes medical treatment is still offered and an option. But if you have your ovaries removed, of course you're going to become menopausal the day that you have the surgery. If you have your womb removed and not your ovaries, there's still a risk that you'll become menopausal quicker, and it's often obviously harder to know if you're not having your periods, and some people obviously have the womb and the ovaries removed. But whether people have treatment or not, like surgical treatment or not for their endometriosis, with time they will become perimenopausal or menopausal, of course. And as you know, in the perimenopause we have a great fluctuation of hormones, especially our estradiol levels. So estradiol levels can become very high when we're perimenopausal, and then they can change and become very low very quickly, actually, over a short space of time. And this big changing hormone levels can trigger or worsen endometriosis in some women, and it can be a worse time. Often people find that endometriosis has been quite quiescent and calm, and then suddenly it can flare up during perimenopause, and that's often due to the changing hormone levels. And then sometimes people think when they're menopausal, because their hormone levels are low, their endometriosis quietens down, and it might happen or it might not. But as you know, in menopause, which lasts forever, hormone levels are low, and there are often symptoms, but also health risks of not having hormones. And so often people come to us to talk about what are the options for hormonal treatment if they've had endometriosis before. The important thing is to know that obviously everyone's different, and the art of having hormone replacement therapy is having the right dose and the right type of hormones for you as an individual. Now, I've already said that estrogen can flare up endometriosis in some women because it can affect the tissue if there's endometriosis left. So we don't know whether it's estradiol or estrone which is more likely to flare up the endometriosis. And estrone is a inflammatory type of estrogen. It's a weaker type of estrogen, and it's estrogen that our fat cells produce, or when we have oral estrogen in the contraceptive, it gets metabolized to estrone. Having estradiol through the skin as a patch or gel is different, and it stays as a pure estradiol. But usually when women have had endometriosis, we give progesterone, and progesterone is a really important hormone, I think, especially for women with endometriosis. Now, some people, if they've had maybe a surgical menopause, they've had their womb, maybe their ovaries removed, the surgeon's really confident that they've removed every last bit of endometriosis, then those women might not want to or need progesterone. But increasingly, actually, in the clinic, I am giving progesterone to women, whether they've had surgery or not, whether they've had their endometriosis deposits removed or not. And we know that progesterone at the right dose is very anti-inflammatory. Now, when it's given vaginally as a pessary, it stays as progesterone. When it's given orally, it's metabolized into other types of progesterone. And some people, and again, this is very individual, but some people respond very well to having a vaginal or rectal progesterone at a higher dose to reduce inflammation and help with menopausal or perimenopausal symptoms. We also know that testosterone is very anti-inflammatory and doesn't usually flare up endometriosis. So sometimes we'll give progesterone and testosterone, and if they need estrogen, just a very low dose of estradiol as a patch or gel. But often, if people, certainly if they've got severe endometriosis with a lot of symptoms, then I will start with a low dose of one hormone, often progesterone, maybe testosterone, but then gradually increase it, optimize that hormone before adding others in. Because just in my clinical experience, if we give estrogen, especially if it's unopposed, if they've had a surgical menopause, then it can flare up any endometriosis that's there. And that's the last thing we want to do, is make endometriosis worsen. So giving those hormones back in an unusual way, if you like, can actually be really helpful. I tend not to prescribe synthetic hormones to people who've had endometriosis. So even the contraceptive pill, I'm just more nervous of because of the way it works metabolically in the body. And we know there's more inflammation in people that have endometriosis. And so thinking about the hormones that are most anti-inflammatory, of course, are our natural hormones, same biological and biochemical structure as the hormones we produce ourselves, but giving the testosterone and the progesterone first before maybe sneaking in some estradiol is often symptomatically actually a lot better for women. There's a little bit of work, but not much, showing that testosterone can be very anti-inflammatory for women with endometriosis. And we know that people who are on the combined oral contraceptive pill, one of the modes of actions is that it increases something called sex hormone binding globulin, which then reduces the freely available testosterone. So another possible problem of having combination oral contraceptive if you have endometriosis is it's blocking the testosterone, which is actually very anti-inflammatory in the body. And there's no reason that people can't have testosterone with the combined oral contraceptive pill, but it might just not work as well because you've still got this blocking action going on. If someone's had Zoladex, like blocking the hormones, then we can give progesterone, testosterone, estradiol if needed at the right dose for that person, and then they can have more of a stable amount of hormones, which can be really useful. So it's making sure that you're having the right type of hormone is important. Any other ways to reduce inflammation are really useful. So it is really important spending time thinking about your nutrition. Do you have any inflammation in your diet, so any inflammatory foods, which often are foods, especially processed foods, can increase inflammation. So you're always better off recognizing the food you eat, having the food that is fresh, if you can, to make, so then you know what's in your food. It's so easy to buy something and think, oh, that looks quite fresh. And then if you look at the ingredients, it's got lots of preservatives in, it's got additives in, and all of these can increase inflammation in the body. So looking at that is really important. Looking at what you drink as well. So drinking water as much as possible, herbal teas. I don't know whether caffeine makes any difference to endometriosis. I haven't read anything either way. Alcohol obviously can increase inflammation, but any soft drinks, even the diet drinks will have chemicals in that can increase inflammation. So looking at that is really important. Obviously, doing exercise can reduce inflammation, but I do know if people are in pain, it's very difficult to do exercise. Looking at ways that we can reduce any stress levels, because stress can obviously increase inflammation as well. Not sleeping, obviously it will increase stress as well. But all these things can work together against us, especially if we're perimenopausal or menopausal. So it's looking at everything one step at a time. One of the things that really saddens me for women with endometriosis is that they're often not listened to, they're not believed. We know it can take about 10 years for diagnosis because so often people are just not believed. They just said, oh, the pain can't be that bad, it can't be that difficult, you've just got to get on with it, you've just got to endure it. And that is wrong in my mind. Just because we don't know what exactly causes endometriosis and treatment might be different for different people, it doesn't mean that women should not be listened to. And I find this is the hardest thing about my job, is that I see and speak to women every day who are just told that it's all in your heads. Now, for us as women, there's no psychological advantage of having things in our heads. We have to listen as doctors and understand and see how we can help that individual. There's nothing worse than being in pain that doesn't improve. But the other thing to think about pain is that we know estradiol, progesterone and testosterone can alter our pain modulation. So they can alter the way our pain receptors respond to pain. And it's been well established in studies that people are more likely to have pain on those days before their periods when hormone levels are at their lowest. And that's another reason thinking about optimizing hormones, so that any pain stimulus that you have is less likely to be felt if you're taking the adequate dose and type of hormones. And that's something that actually a lot of pain specialists don't realise, but is really important to consider. If people are just having symptoms just for those few days before their periods, then often we can just top up the hormones on those few days. People don't have to have hormones all the time. But the important thing for women with endometriosis is to try and not have these big swings of hormones, these fluctuating hormone levels, especially estradiol, because then that can sometimes trigger worsening of symptoms. People can still use vaginal hormones, whether they're having systemic hormones or not. If people are having symptoms related to vaginal dryness, soreness, irritation, if they're having urinary tract infections or cystitis or passing urine more frequently, then vaginal hormones can be really, really useful. Some people I've known even have a flare with vaginal estrogen like Vagifem, but increasingly in my clinical practice I prescribe prasterone or Intrarosa is the other name in the UK, and that contains DHEA, which converts to estradiol and testosterone in the vagina, and then that seeps out into the bladder, the surrounding tissues, as well as the pelvic floor. So if you've got any endometrial deposits around the vagina, in the sort of either around in front of the bladder or around the bowel, then actually having prasterone can help, because the testosterone is very anti-inflammatory. There isn't a way currently of having just pure testosterone pessaries, but the estrogen dose is very, very low. But having the DHEA, which converts to testosterone and estrogen, is often a lot calmer and a lot more soothing for women if they've got localized symptoms. And that is important whether you take HRT or not. If I'm concerned that a woman has quite severe endometriosis despite having had surgery, or there's a chance that the surgeon hasn't removed all the endometriosis and this lady's had a surgical menopause, then I usually give progesterone. And increasingly, for most women who've had endometriosis, I will talk to them about having progesterone, because I've done a YouTube or an Instagram live about progesterone already. But so many people think progesterone is just for the lining of the womb. But actually, we know that it helps. It's the rest of our body. It's an important hormone for our brain, for our bones, for our muscle, for our heart as well. And so increasingly we give progesterone at the right dose for people. And when people have had a surgical menopause, progesterone can be very useful. But with endometriosis, women with endometriosis, then I tend to talk about progesterone earlier than I did in the past and offer it earlier. And often a higher dose vaginally can be really beneficial. When it goes in the vagina, it gets absorbed through the mucous membranes straight into the bloodstream as the pure progesterone. There are progesterone creams that are possible to buy, but the absorption isn't reliable. So certainly if someone's still got their womb, you want to make sure you have an adequate dose of progesterone, and increasingly giving it vaginally can be really useful. It's not licensed in that way, but as you know, we give a lot of drugs in different ways off license, and that's absolutely fine to be considered. Katrina Dalton wrote a lot of really amazing work about using vaginal hormones at higher doses. So if some people haven't had good experiences of being on hormones, then it's really important to think about the dose and the type, because some people will try a low dose of maybe a synthetic HRT and say, no, it made my endometriosis worse. And it might do, but actually if you unpick it and have the natural hormones, it can really make a huge difference. And like I say, thinking about the progesterone and the testosterone before estrogen can also be very, very beneficial. If people find that they have flare-up of their symptoms with a contraceptive pill, then I would certainly think about having natural hormones, regardless of your age actually. If people have got adenomyosis or they've got the endometriosis deposits around their womb and their pelvis, then having something like a Mirena coil, the progestogen low-dose coil intrauterine system, can sometimes be beneficial, but it will only work locally. It won't help suppress inflammation in the body and help any other endometriosis deposits elsewhere. So what I would think about is, even having had a Mirena, think about the other hormones and the role of testosterone, progesterone, plus or minus estrogen. So it's just thinking about the hormones in different ways. Obviously they can help with any perimenopausal and menopausal symptoms, but what I really think about is how we can reduce inflammation and suppress any endometriosis in the body. And often I'm speaking to women who have been given like a Zoladex injection by the gynecologist with no add-back hormones, and they're feeling dreadful, like really awful. I spoke to someone recently when I was in a prison, and she works in a prison, and she said, I just feel like I can't function, I can't think, I've reduced my hours, I have such bad brain fog. And then when I spoke to her, she said, yeah, I've had endometriosis and I've been given Zoladex, and because the waiting list is too long for surgery, I've been told to just keep having these injections regularly. And no one has spoke to her about her hormones, and she will have just gone into this chemical menopause very quickly. So we need to be really thinking what we're doing and what are the side effects of the treatment that have been given for endometriosis. I have got a podcast coming out with endometriosis soon with Jen, who's got a lived experience of endometriosis, who does a lot of campaigning. But it's really important to speak to the right doctor or even group of doctors. Like I say, I'm not a gynecologist. I don't usually actively treat endometriosis, but I see the problems when people are given the wrong treatment or not looking at in a bigger picture, especially if they've had a surgical menopause or they've had their hormones blocked by treatment to try and suppress hormones. It's not always the best thing for women with endometriosis. So looking at you as an individual is really important. Getting help, support, advice and treatment from the right person is really important. But the most important thing is not to suffer and know that there are options. There absolutely needs to be more research in endometriosis, and it should be looking at inflammation and how to reduce inflammation. And there is an association in some women with endometriosis, polycystic ovarian syndrome, even fibroids as well. And we need to be looking, and even Ehlers-Danlos syndrome, there's this big overlap for these women. And what is it about them? Is there a genetic reason? Is it more of a hormonal balance? Are they more testosterone deficient? Like, we don't know, because the research hasn't been done, and it really does need to be done to try and help more women have better pain-free, symptom-free lives when they have endometriosis. So I hope that's been helpful. I'm going to post some links to some resources on my stories, and it's great to be back doing the Instagram Live at 6 o'clock. Next Sunday I'm going to be in Ilkley in Yorkshire, because my tour then does 10 days back to back before it finishes, and I must say I'm really loving doing the tour, meeting so many people, listening to your stories, getting instant feedback about how the work I do, the educational work, is making a really big difference to empower your lives. So next week I'll probably do my Instagram live in the late morning. I'll just need to think about the logistics, but I will do it on the Sunday for you. So I hope that's been helpful. Great that you've logged on, and enjoy the rest of your evening and have a fabulous week. Thank you.